topic of the lecture today is pneumoconiosis. Whenever the word pneumoconiosis comes in front of you, you have to define whether it's obstructive lung disease or restrictive lung disease. So, let me tell you, it's a restrictive lung disease. Let's differentiate between these two diseases. Obstructive lung disease is the disease in which there's a problem in expiration of the air. And restrictive lung disease, there's a problem in even inspiring the air. So all the pneumoconioses are going to be restrictive lung diseases. And restrictive lung disease, what will happen if the patient is unable to inspire, if the patient is unable to fill his whole lung, if the patient is unable to attain that total lung capacity that lung is going to have, if that's not happening, it means the volume of the air inside the lung is markedly reduced. So what will happen? Forced expiratory volume in 1 second will either remain same or slightly reduced. But what will happen to forced vital capacity? That reduces to much extent because that whole volume, which was supposed to be emptied because of that resistance inside the alveoli, is gone now. Because of fibrosis, some areas are not even containing the air. So because of that, forced vital capacity is going to drop dramatically. So if FEV1 or FVC of a normal patient is going to be 80%, in the case of restrictive lung disease, it's going to be more than 80% because FEV1 is the same or slightly reduced. For example, if FEV1 of a normal patient is 4 liter, meaning that he expired the air in 1 second, that volume is 4 liter, and forced vital capacity was supposed to be 5 liter. So it added up to 80% of this. But if FEV1 is reduced to much lesser extent or stays the normal, for example, it goes to 3.5 liter. But FVC is going to drop dramatically. It's going to go from 5 to 4. Now it's 3.5 by 4. So what will it be? It will be more than 90% or equal to 90%. In severe cases, it might lead to 100%. So to define that it's a restrictive lung disease, we have to know that its FEV1 or FVC is going to be more than 80%. So pneumoconioses are restrictive lung diseases, meaning there's a pathology that's not letting the air in, that's not letting the total lung capacity to be optimized. So let's talk about pneumoconiosis, what comes under the headings of it. First of all, whenever we talk about pneumoconiosis, we're going to have to remember two very basic concepts. As you can see, these are your lungs, trachea, larynx, everything is there. So what happens? First of all, we have to define what inhalable microorganism, what inhalable structures, what inhalable elements can go up to the level of alveoli. What structure will stay there, what structure will go out, what size is going to enter, what size is not going to enter. So let's define. So any structure, any element that contains a size of 5 to 10 micrometers goes to the upper respiratory tract. It just goes to the upper respiratory tract because that area has this size limit. Above that, you cannot inhale it. So when it reaches the thoracic level, the size goes down to 3 to 5 micrometers. So anything, any material, any element whose size is more than 5 is going to get stuck here because it's not supported otherwise. It's not supported further. But at respirable area, the size go down to dramatically to 1 to 3 micrometers. So the whole point of telling you all of this is that the structure, the size of the structure goes down and down and down up till the level of alveoli. So at the level of alveoli, the structure must be 1 to 3 micrometers for each alveolar level. So any structure who is more than 10 micrometers, any element who is more than 10 micrometers is not even going to get in. And structure which are more than 5 to 10 micrometers are going to get stuck in your nasal cavity or something. The structures who are 5 to 10 micrometers are going to get in, but they're going to get stuck right here because thoracic level supports only 3 to 5 micrometers. And further away, when we go to alveolar level, it will only support 1 to 3 micrometer structures. And what if the structure goes down below 1 micrometer? It's so tiny that it will go in, yes, it will go to alveolar level, but it will be expired out eventually because it's so small, it's so tiny that it won't hold inside the alveoli. So we have to define that what size matters in this pathology. Any particle who has a size of 1 to 5 micrometers is going to matter because this is a size which can get stuck anywhere in here, anywhere in here. It can get stuck here, it can get stuck in the respiratory tree, it can get stuck at alveolar level, but mostly it gets stuck in the bifurcation areas. When there's a bifurcation, it can get stuck in there. It will not leave. Its size is enough to hold. So when that kind of structure gets there, what happens? And that's the second point of our pathology. Macrophage gets attracted towards it. There are two kinds of macrophages present in the respiratory system. These are alveolar macrophages and then there are respiratory macrophages. Both of them get attracted towards that foreign substance. It's a foreign substance. There are going to be some kind of repercussions in the system. So those macrophages come in. So these two things are very key points to knowing the pneumoconiosis. These two things matter, macrophages and the size of the particle. Now we're going to talk about that what happens afterwards. What happens is that macrophages come in, they eat that particle. They want to kill that particle, so they eat that particle. The moment that particle gets inside of your macrophage recognizes that it's a foreign substance and we have no past history of that. No antibodies ready for that. So it will run to the lymphatic system. Lymphatic system is always nearby. So it's going to run to the lymphatic system, and the lymphatic system, it's going to go to its friends, which are helper T cells or lymphatic cells. Lymphatic cells will identify that there's a problem, and that starts a cascade. All of the inflammatory mediators will start pouring out in the lung at that point in which this foreign substance is coming in. So what will happen that all of the collagen fibers, lymphocytes, neutrophils, eosinophils, they all will start accumulating and this will lead to inflammation. That inflammation will happen again and again if the patient is exposed to that kind of environment chronically. It goes on and up till the point that it leads to fibrosis. It leads to a point when fibrogen comes in. That's the point where fibrosis occurs. So this happens, all of this happens because of chronic exposure to a substance which is fibrogen in nature, which is fibrotic in nature. So we're going to talk about all of the agents that might cause this kind of pathology in detail. First of all, let's talk about silicosis. What happens with silicosis is that a person is going to be subjected towards a very high pressure of silica. So people who work in mines, yeah, they are also subjected to coals, but they are also subjected to a very high level of silicon. And the other people who are going to get this disease as sandbusters. You might be wondering what sandbusters are. Sandbusters are people who clean the buildings by pouring very high pressure of sand on the brick, on the tile. So it contains a very high amount of silica. That person is going to ingest all of it. That person is going to get silicosis in order to compensate in the lungs. So let's talk about it. As you can see, silica dust goes in, and then all the other pathology is just the same as pneumoconiosis as we discussed earlier. But there are very slight differences. Let's talk about the differences here. That what does differ between these two? So when a macrophage gets in, when a macrophage is here and silica gets in, macrophage is going to engulf it. When it engulfs it, it goes back to lymphatic system and tells that there's a foreign substance, and then all of the other mediators are going to come in, like fibrogenic factors will be activated. What happens is that these silicon crystals will start accumulating. Silica crystals are going to get accumulated in the base, and what happens is all the other collagens, all other fibrogenic factors, all the other structures that are present there are going to accumulate around it. They're going to form a structure, they're going to form a pattern. So in the base, there's going to be large amount of crystals of silicon which are surrounded by fibroblast, macrophages, lymphatics, a lot amount of collagen, and then as cell injury is happening all the way, calcium is released from the cells. As calcium is released, it will start accumulating around it. And at the end, you can see an egg shaped structure, an egg blast shaped structure. This is called silicotic nodule. So, what's the end product of silicosis? Silicotic nodules are formed inside the lungs. So, they will compromise the whole respiratory zone. They will compromise at least one area. What will happen? This area won't communicate in respiration. This area won't help in respiration. So, that's why it's going to lead to restrictive lung disease, because many of the areas of the lungs are not even communicating. So they're not even taking the air in, they're not like letting the air go out. So they are just dead. They are just nodules. So the total lung capacity is going to reduce, as we talked about earlier. So what are the clinical features that a patient present to you with? First of all, there will be chronic cough because there are nodules formation, there's a lot of infection happening that will irritate the lining. Then there will be dyspnea because the person feels like he's not getting enough air. He's hungry for air. He's not getting enough air because many of the respiratory zones are compromised now. They're not communicating. They're not doing their work. It will lead to chest pain and fevers because there's going to be infection, obviously. And that infection will lead to fever. Afterwards, there'll be fatigue, and you can also see the loss of appetite in this kind of patients. So, when you go for chest PA X-ray of the patient, what will you see on chest X-ray? What will you see on radiology? Let's compare. This is a normal lung, normal parenchymal tissue, but this is a patient who is suffering from silicosis. What do you think will be the area which is subjected most to silicosis? What lobe do you think will be most affected? It will be the apical areas. What's the best way to remember it? Where does silicon come from? From the coals, from the mines, from down below. From down below, we take it up. So it's going to take upper areas. So at radiology, you can see silicotic nodules are formed, and then you can see all the patches present here. This is how the patient will be seen on the chest X-ray. This is how the patient's chest X-ray will be seen. Next, let's talk about morphology. I just told you that in the base there will be a lot of crystals, then it will be contained and it will be surrounded by collagen fibers and fibroblast cells, and then it will also contain macrophages, and at the end there's accumulation of calcium which gives it a shape, which gives it that egg shape formation, as you can see in this morphology. What will happen in acute cases? In acute cases, there will be a flare-up, as you can see in this case. Silicotic nodules are not formed yet. They're in their process. A lot is happening. Infection is happening inside the lung. Many areas will go dark. And afterwards, as you can see in morphology or in histological slide, this is how you'll see. This is how it will appear on histological slide, on histopathological slide. That you can see infection is happening, a lot of cells are here, a lot of reactions are happening, spaces are increased. Then comes accelerated silicosis. When a person is being subjected to silica in very high amounts for a very long time, it will accelerate the whole process. Then it leads to that point in time that if you remove that exposure to silica, patient won't improve, because he has been subjected to enough amount of silica that he won't recover now. All you can treat is his symptoms afterwards. So when a person is exposed for a very long time, for a very high amount of pressures, this happens. It even compromises the whole lungs. It even can compromise the whole lobe of the lung. Then comes progressive massive fibrosis. When a person reaches that point, that he has been subjected to enough silica, he has been subjected to enough silica for a long time. There's no turning back. All you can treat is the symptoms. Progressive massive fibrosis happens. Massive areas of the lungs are going to get fibrosed. Why? We talked about that. When a person is getting infection, when a person is getting infection due to silica and its crystals, a lot of processes are happening, a lot of inflammation is happening. When that happens again and again and again and again, without that contamination being out of the whole system, what happens? Fibroblast cells come in, and to wall off that phenomena, remember this line, wall off that phenomena, they fibrose that area of the lung. That's how you get progressive massive fibrosis. Now, what will happen to a patient who's been there for a very long time, not been treated and not been taken out, and that exposure is not removed from his life? This kind of X-ray you will get. Now it's diffused. The whole pathology will get diffused. It won't be limited to one lobe or the second lobe or the third lobe or only one interstitium or two interstitium. This will be leading to diffused kind of fibrosis of the lung. Now let's talk about silicotuberculosis. It's the only type of pneumoconiosis which lead to increased chances of tuberculosis in that person. I'm going to mention the pathology that leads to silicotuberculosis. When silicon gets in, its structures, its rods, its crystals are there. What's the macrophages are going to do? They're going to eat that. They're going to kill it. And in order to kill it, they're going to eat it, and the moment it gets there, it impairs the function of phagolysosomes. What are phagolysosomes? Phagolysosome is a whole system in which phagosomes are the vesicles that are released when it tries to kill something, it tries to eat something. It has to kill something, it will release phagosomes. And what lysosomes are? Lysosomes are when they're grouped together in order to kill something. So when phagolysosomal activity is impaired, body is very, very prone to infections. In our environment, TB is very common, but that phagolysosomal activity prohibits it from happening to that person. But when silicosis is happening and phagolysosomal activity is impaired and macrophages are not working at their best, that person is most prone to develop tuberculosis. So in a patient who is already having silicosis, if that person is going to get TB, what areas do you think will be more prone to that infection? Apical areas. As you can see, these apical areas are going to get TB. So that's all about silicosis. Now let's talk about cold worker pneumoconiosis. It's also called black lung disease. Why it's called black lung disease? Because we're going to inhale coal all the time for massive amount of period. As you can see, this is a normal lung, but this is the lung of a coal worker who's getting pneumoconiosis. Because the whole areas of the lungs are getting blackened, that's why it's called black lung disease. As you can see, large nodules are formed inside black lung disease. These nodules vary from size to size. That lung gets stiff and it cannot fully expand because many areas are not functioning at all. It's decreasing the total lung capacity. Progressive massive fibrosis will happen if the patient is exposed to that kind of environment for a very long time. As you can see, it will block all the alveoli, it will blacken them, it will just destroy the alveoli and a bunch of them. So this will lead to lung stiffness, and there will be no respiration in that area. There will be no gaseous exchange in that area. As you can see, gas exchange was going to happen here. It was supposed to happen here because the alveoli are blocked. Alveoli are dead. So there will be no gas exchange, or if it's going to happen, it's going to be very minor. As you can see, inflammation happens because it's an infection. When infection happens, inflammation is going to happen because all the mediators are going to come in, as we talked about. As you can see, alveolar septum is dissolved because of this infection, and because of that deposition of coal, it's going to get dissolved one way or another, and it will lead to scarring. As you can see in the slide, it will lead to scarring of that whole epithelium. And large cavity lined with coal particles is seen. It's called anthracosis. We're going to talk about it. Now let's talk about coal worker pneumoconiosis and what's going to happen with the pathogenesis of it. When a coal worker is working inside a mine, it's going to inhale a lot of coal. Normal amount of coal won't affect that much, but a massive amount of coal for a very long time, for a very chronic exposure, will lead to the following consequences. First of all, coal will be inhaled, and as you can see, the particles are going to get there, and then macrophages are going to take that in. Macrophages are going to destroy that because it's a foreign particle and its size of 1 to 5. It's gonna get there. That macrophage is going to engulf it, and what happens afterwards? It will go running back to the lymphatics to call for help. What will happen? All the inflammatory mediators are going to come in, and they will cause inflammation. But what happens with the macrophage? What happens with the alveoli? That macrophage is going to get dead or black. That's why it's called black lung disease. That macrophage is no longer working. What happens to the alveoli is that it's going to get affected. It's going to increase that size of alveoli. It's going to get dilated respiratory bronchioles because it's going to make them stiff. It's going to make them dilated. It's going to get impacted there. It's going to get stored there because there's not enough size of that particle to get expired out. This doesn't happen in normal cases. This happens only if the patient has been exposed to that kind of environment for a very long time with a very high pressure. As you can see, focal dust emphysema happens if the patient is inhaling for a very long time. These respiratory bronchioles will get dilated with the coal being impacted all over here. And this will lead to focal dust emphysema. This will only be present in that focal area which has been subjected to the most of it. What areas do you think will be subject to the most of it? Apical areas or the base areas of the lung? Apical area. It's the same sense. We talked about silicosis. In this, the coal has been taken out of the land. The coal has been taken out of a mine. It's taken out from the down. So it's going to take upper areas of the lung. Now let's talk about that what if the coal worker pneumoconiosis is simple, and what happens if the coal worker pneumoconiosis gets complicated. In a simple coal worker pneumoconiosis, 1 to 2 millimeter of coal macules are formed. And there are large nodules present. Large nodules are going to be present whether it's simple or complicated. But the size of the coal macules are going to be very small. It's going to be 1 to 2 millimeter. And this is reversible. If the patient is taken out of this environment, this will be all right. This will get fine on its own, or after some treatment, it will be fine. And that black lung tissue that we talked about is going to be that area in which these macules and nodules are being formed, and that coal is being impacted and stored. So what will be the consequences symptom-wise? Symptom-wise, what consequences are going to be there? What are we going to get? First of all, we're going to get cough, obviously, because we're going to get subjected to this kind of environment. We're going to get cough because there are nodules and macules are being formed inside the lung, and there's always irritation and infection is happening inside the lungs. What will happen with wheezing? Patient is not getting enough air. The airway is compromised. And there will be shortness of breath because of all of this area being compromised and not enough oxygen being given to the blood. The patient is going to experience wheezing, that he is not getting enough oxygen. He wants more. He's going to get hunger for that air. He's going to get hunger for that oxygen. But what happens if that coal worker pneumoconiosis gets complicated? In a complicated coal worker pneumoconiosis, the nodule size will be 10 millimeter or greater. We talked about it that it will be 1 to 2 millimeters in simple, but it's going to get 8 to 10 millimeter in greater nodules, with greater nodules. That lung will be stiff and unable to expand fully because the size of the nodules and macules are so great that they're not functional enough to expand to their full content. So what will be the symptom-wise complication? The patient will be short of breath during physical effort. Whenever he will try to run and the body will try to compensate with more oxygen being supplied to the blood, shortness of breath will happen because not much area is participating in gases exchange because of cold worker pneumoconiosis. Further, we're going to get inky black sputum producing cough. And it'll cough because of that black lung, because of that store inside the lungs of coal. That sputum will be black in color. Milky gray, clear, or cola black sputum, we already talked about it. There will be yellow, green, or thick sputum because there's more and more of infection. And you get yellow sputum when there's very high amount of infection is going on inside the lung. Then we will get bluish tint of fingernails and lips. Why do you think is that happening? Because when not enough oxygenation is happening, not enough gases exchange is happening, blood is not filled with oxygen. Blood does not contain that much amount of oxygen. So where will be that oxygen supplied? It will be supplied to that basic organs, to the vital organs, to brain, to heart, to liver, to kidneys. But in the peripheral areas, the amount of oxygen that reaches the peripheral areas are going to be very low. So that's why the deoxygenated blood will get there. And that's why we will get the tint, bluish tint of the fingernails and lips, because these are peripheral areas, these are distant areas which are supplied at the end of the circulation. We'll get trouble breathing because not enough air is getting in because most of the areas are compromised. There's restriction. That restrictive lung disease concept is going to get implied here. There's restriction to air coming in, so there will be trouble breathing and severe shortness of breath because the whole time person will be trying to compensate for that area which is not participating in gases exchange. Now let's talk about the morphology of cold worker pneumoconiosis. As you can see, it's a black lung disease. It will lead to this kind of structure afterwards. It will be whole black because of that massive amount of accumulation of coal inside the lung. As you can see, massive amount of coal is here, massive amount of accumulation happened in here. That's why it's called black lung disease. Now let's talk about a phenomena which is going to happen in a cold worker pneumoconiosis. It's called anthracosis or anthracosilicosis. What's anthracosilicosis, you might wonder? This is a problem in which carbon deposition happens inside the lung. It's a benign condition, it's not going to affect much, but when a person is subjected to that amount of coal for that long time, that carbon deposition starts happening. That carbon deposition will lead to anthracosilicosis. As you can see, large amount of carbon is present here. This will blacken the lungs. This will lead to this kind of structure afterwards. As you can see, large amount of structures are going to get subjected to anthracosilicosis, and this will keep accumulating if the person is being subjected to that amount of coal for that long time. Now let's talk about what will happen in asbestos-related lung disease. I'm going to nominate that which pathologies are going to happen, and then we're going to talk about all of them in detail. First, it will be a normal lung, and when it's going to be subjected to asbestos, what will happen? Pleural plaques will happen. Chances of lung cancer go up to 7%, go up to 7 times. Asbestosis will happen obviously because it's being subjected to a large amount of asbestos for a very long time. Plaques on diaphragm will happen, and mesotheliomas, the chances of mesotheliomas happening in an asbestos patient go up to 1,000 times, that much. Now let's talk about the pathogenesis before we get into all of these consequences. Let's talk about what happens when a person is going to get subjected to asbestos. First of all, asbestos will come in. There are two kinds of crystals of asbestos. They're going to be either spiral or amphibole. Spiral going to be zigzag pattern, and amphibole is straight crystals. Which crystals you think will get to the alveolar level? Straight ones, because the spiral ones may get inside your nose, may get inside your system, but they are caught or they hang in there on the upper respiratory tract. And even if they make it to the lower respiratory tract, even if they make it to the lungs, they're trapped. And then mucociliary escalator helps to remove them. But that straight crystal of asbestos goes straight down to the alveolar level, goes straight down to the respiratory zone. And that's why those amphibole crystals, those straight crystals are going to be more dangerous. As you can see, only straight crystals are getting here. And that spiral shape, this kind of shape is not getting here. You're only getting amphibole crystals of asbestos. These are going to get there and macrophages are going to get activated. They're going to want to eat them. They're going to want to eliminate them. So what will they do? They will engulf them. They will try to eat them. They will try to eliminate them. But the moment they'll eat them, the moment they're going to eliminate them and they're going with phagolysosomal activity, what will happen? They will induce them, but afterwards they will go running back to lymphatics and try those helper cells for any kind of help. So a lot of accumulation of interleukin, CD4s, and all of those cells and all of the inflammatory mediators are going to get there. As you can see, it went there, but these crystals are getting stuck in here. These crystals are getting accumulated in the base. These crystals are getting more and more in number in here. So what will happen? The fibroblast and the collagen fibers are going to get here, but with time, the accumulation of these crystals are going to be very large. They're going to be very large amount of crystals which are going to get accumulated in the base. These are called asbestos bodies. What are asbestos bodies? When the macrophage tries to kill that crystal of asbestos, it releases iron in the form of ferritin. That iron or ferritin accumulates around that crystal. And if it doesn't kill it, even if it kills it, these bodies start accumulating in the base. These bodies, which contain a crystal of asbestos lined by ferritin, these are called asbestos bodies. So these are present in the base. And what will happen? These keep accumulating and accumulating, and this will lead to distal air spaces and interstitial fibrosis. We already talked about what fibrosis is. Fibrosis is not an immediate process. It will take a very long period before this happens. Because these macrophages are going to get that inflammatory mediators, inflammation will happen, it will happen again and again and again and again, and at the end, fibroblastic activity will come in to wall off that phenomena. As you can see, in asbestosis, this will happen. Terminal bronchioles will be constricted, the distal air spaces will be open, and there will be a lot of asbestos bodies present in here. What are the stages of evolution in asbestosis? At what stage do you think there is no turning back? Patient is not going to get better. Even if you remove that asbestosis in the environment, it's not going to help. What stage is that? Let's talk about it point by point. First of all, you get exposed. You are working in that environment in which the asbestos is present. You're working in aerospace industry, you're working with old pipes. So you're going to get exposed and you're going to get inhalation of that fiber, inhalation of those asbestos fibers. We already talked about there will be two kinds of crystals. There will be either spiral or amphibole. Spiral crystals are going to get stuck inside your system and then mucociliary escalator will remove them. But the rod-shaped crystals are going to get in and get accumulated. So there will be a latent period. There will be a long amount of period. For every person, it's different. For every person, it varies from months to years. If a person is exposed to asbestos and that asbestos has started accumulating inside your lungs, and the whole process has been started. If it happens again and again, this will lead to shortness of breath with exertion, because now most of the areas are going to get fibrosed. Most of the areas are not working. Most of the areas are under the effect of inflammation, because there's huge amount of infection present inside your lung. There's huge amount of foreign bodies present inside your lung. So that area of the lung is not contributing in gases exchange. So that person will get shortness of breath when he'll try to run, when he'll try to work. What happens afterwards? Shortness of breath at rest. Before it, there were only few areas which were compromised, but the body was doing fine at rest. Body was compensating for those areas which are not working. But now, the extent of the whole damage is so much that it has compromised like 20 to 30% of the lung space. Most of the space is not working. Most of the space is not contributing in the gases exchange. So what will happen? The patient will get shortness of breath at rest, because even at rest, even if he's not doing anything, lungs are not doing their function enough to supply the whole body with oxygen. Patient will feel that hunger for air, that he's not breathing enough. Then there'll be difficulty swallowing, because there's a huge amount of inflammation. Patient will be unable to even swallow. Then reduction of lung function will happen. How will that happen? We already talked about it. It's a restrictive lung disease. Because it's a restrictive lung disease, many of the patches, many of the areas of the lungs are not working. As they are not working, functional vital capacity of the lungs are going to get reduced, and that will lead to reduction of the lung function. Lung doesn't have that amount of space present inside them to compensate for the whole body's gas exchange. So the reduction of the lung function will happen, and at the end, lung and heart failure will happen. Why is that happening? Why heart failure? Because if lungs are not good enough for the gases exchange, what will happen? Right ventricle will be subjected to more pressure. Heart and lungs are interrelated. They are a circuit. If lungs are not working, blood is not getting that oxygen which it requires for the normal functioning. So what will happen, that those arteries, those veins which are passing through it will pass, the blood will pass more slowly, so that blood might have increased chance of getting that oxygen, specifically in those areas which are still contributing to the gases exchange. So if it doesn't happen, the blood will slow down. If the blood slows down, the pressure will increase on the right ventricle, which will lead to right ventricular failure, which will lead to right atrial failure, and in turn it will lead to heart failure. And lung failure is already happening, because most of the lung space is being covered by this substance. Most of the lung space is going to get subjected to fibrosis. So what will be the morphology of the asbestosis? In morphology, there will be bead kind of appearance. As you can see, bead appearance will be seen because these asbestos bodies were laid down, they were present inside the base, and in turn, that accumulation and that degradation will lead to this bead formation, as you can see here. As you can see, these crystals are present, these amphibole crystals are present inside the cells. When you put them on histological slide and see them under the microscope, you can see these crystals right here, and you can see the fibrosis all around. Now let's talk about the consequences of asbestosis. The consequences are the pleural plaques. We talked about pleural plaques, that these are asbestos bodies which starts accumulating inside the base, and they're accumulated, and this will lead to the formation of plaque, and that plaque is called pleural plaque. As you can see, the formation of pleural plaques inside these structures. Next, we're going to talk about a very important thing called mesotheliomas. Mesotheliomas are actually the cancers of pleura. As you can see, this is a normal lung. It's always covered by two layers of pleura, visceral layer and parietal layer. As you can see, this is pleura, but this is the inner covering of it. In mesotheliomas, the pleura is affected badly. The pleura is affected and the cancers of the pleura form. These are called mesotheliomas. In a patient of asbestosis, the chances of getting mesotheliomas are greater. They are even up to 1,000 times. So it won't be wrong if you say that if a person is suffering from asbestosis, it's going to get mesothelioma. What will happen? This mesothelioma will lead to further pathologies. As the parietal layer, as the visceral layer is getting that cancer, it's getting that tumor, it's going to get to more pathologies as the layer is now compromised. Between these two layers, there's a very minute amount of fluid present, which gives it a cushion inside that inspiration and expiration phase. In some cases, that fluid is increased dramatically. And if there's a tumor now, if there's a cancer now, that fluid will leak into it. And we're going to talk about how that happens. But when you look at a patient who suffers from mesothelioma, this is the lung looks like. As you can see, the whole pleura was destroyed and mesotheliomas happened to this lung. Now let's talk about how that pleural effusion worked. I told you that there are two layers, outer and inner layers, and between them there's a certain amount of fluid present to provide that a cushion in inspiration and expiration. If there are mesotheliomas now, what will happen? That fluid will leak in. That fluid will leak in and it will lead to benign pleural effusion, as you can see in here. This pleural cavity, and now pleural effusion happened because that amount of fluid which was supposed to provide that cushion is now compromised. Now that fluid is leaking in and causing the pleural effusion, as you can see in here. And this fluid buildup will keep increasing if it's not taken care of. This will lead to further pathologies. This will lead to further fibrosis. And this will lead to diffuse pleural fibrosis. How will that happen? If you know that a lung is just like a sponge, if a pressure is applied, it will stop working, it will just squeeze. And when a high amount of fluid is building up inside a lung and asbestos infection is happening and that pleural plaques are being formed, it's more prone to the formation of pleural fibrosis. Those fibrogenic agents will get there, fibrolysis will happen, and diffuse pleural fibrosis is the major pathology seen inside the asbestosis patients because there are huge factors which are promoting the formation of fibrosis. As you can see, a lung which has been subjected to diffuse pleural fibrosis, all of these areas are destroyed, practically destroyed, and they're obviously unable to even carry out a very tiny amount of gaseous exchange. Rounded atelectasis. This is the fifth pathology which will be seen in a patient who is suffering from asbestosis. In rounded atelectasis, that pleural space which was supposed to support and provide cushion has been compromised due to either mesotheliomas or something, and this will lead to what? This will lead to pleural effusion, and that pleural effusion is going to put pressure on it. That pressure which was not there before, all of these pressures are going to get cancelled, and at the end this will lead to atelectasis formation, as you can see in this photo. What is atelectasis? Strengthening of the size of the lung, or destruction of that area. So if pleural effusion is happening, if mesotheliomas are happening, they will affect that part of the lung, and this will lead to atelectasis of that part of the lung. It's always focal, it's not diffused. So what do you think will be the differentiating point between all of these? We talked about Kohlberger pneumoconiosis, we talked about silica-contaminated, we talked about asbestos-related pneumoconiosis and asbestos-related lung diseases and their pathologies. All of them have the same basic pathology. Coal came in, silica came in, asbestos came in. Macrophages took them up, they went to the lymphatics, they called upon the inflammatory mediators and works and stuff like that, and they all led to their final product. In this, it was focal dust emphysema or black lung disease. In this, it was silicotic nodule formation. and in asbestosis, it led to interstitial fibrosis. What is berylliosis? Berylliosis is actually present inside the patient which have been subjected to it for a very long time. In this patient, antigen presenting cells are subjected towards the beryllium. They produce Th1 cytokines, IL-2, IFNY, and TNF, tumor necrosing factors, and this leads to macrophage activation. Just like the other pathology we talked about earlier, that macrophage will be activated, it will release cytokines, tumor necrosing factors, and stuff like that, and this will lead to the formation of this pathology. This is called berylliosis, and this happens after a very long exposure of beryllium. This leads to non-caseating granuloma formation. But keep in mind that yes, it's causing non-caseating granuloma formation, but it has very high chances of converting that into cancers. Very high percentage of cancers in the patients who are suffering from berylliosis. In the pathology of berylliosis, as you can see, non-caseating granulomas are seen. This is the identification point for berylliosis. Now, what do we see when a patient of berylliosis is subjected to the X-rays? This is how you see a patient who's suffering from berylliosis. As you can see, all of these granuloma formations, non-caseating granulomas are formed, and acute infection is happening already. So this is how the X-ray PA view will be seen, and this is how it will be seen from up. Now, the last topic is talcosis. What's talcosis? First of all, before we get to the histopathology of talcosis, let me tell you what talcosis is. Talcosis happens in those patients which are IV drug abusers. This is the only cause. There's no other cause. Patients who are the IV drug abusers and they convert one drug from one state to another state. For example, if a powder is there and they heat it up and they convert it into a liquid, in case of heroin, they convert it into a liquid, they take it inside a syringe and they inject themselves with it. So they're IV drug abusers. That drug is going to get to the lungs eventually. To get the blood oxygenated, heart will pump the blood to the lungs. Inside the lungs, that drug which was converted from solid to liquids will now be converted back to the solid. And it will work as a cement. It will block it. The whole blockage will occur. There will be no gases exchange in that area afterwards. This completely ruins the lung. This completely stops the gases exchange. And it's progressive. The more you inject that kind of stuff inside your body, the more part of the lung will be affected. The more restriction and restrictive lung disease will happen. This is how it will be seen on pathology and pathological side. You can see this infection, but the blockages are very visible in this case. There's not enough space left after this for gas exchange to take place. In a radiological patient, you can see, look at that. These spaces you can see like cement blocks or something. There's nothing going on here because there's no gas exchange. These are like cements. You can see them, these white patches, very, very thoroughly. So that concludes our lecture on pneumoconiosis. So we learned that it's an occupational hazard which occurs in those patients who are working in that environment. If we remove their antigen, if we remove that person from that environment, person can actually get better in some cases, up to some extent. But if the nodules are formed, if the patient is already in the very chronic form, there's no going back. All we can do is treat his symptoms. So things you have to remember is that all of the pneumoconiosis, all of the disease included in it, all of the pathologies included in it will lead to restrictive kind of lung diseases. The FEV1 or FVC will be more than 80%. The pathology is kind of same. You just have to differentiate them from obstructive lung diseases. And you have to look out for asbestosis in particular because the chances of getting the lung cancer in asbestosis is 7 times rather than other diseases. Thank you for watching sqadia.com.